How you doing? I'm doing a little Murmur Basic talk. This is talk we should have had probably a week or so or two ago. Didn't get to secondary two, just not enough time, extra lectures and stuff like that. Today we're just going to kind of focus on murmurs. Hopefully, I hope to post videos, on all your big valve lesions like aortic stenosis, aortic regurg, mitral stenosis, mitral regurg, and then some of the splittings, your ASDs, and just some of your other kind of big heart sounds, your S1, your S2, 3, and 4. So those type of things. Hopefully all that'll come, but this time we're just going to kind of talk about numbers. So first thing, what's this thing? Everybody kind of knows what it is. A stethoscope. So good. All right, so we have our stethoscope here. What's it for? So what is our purpose, our goal? Remember, I like goals. So what is our goal of this thing? It's kind of a screening tool, right? We're going to kind of use it as a physical exam screening tool for pathology. So you can listen to the abdomen. Do they have bowel sounds? We can listen over vessels. Do they have bruits? We can listen over the lungs. Do you hear gophony or bronchophony? Something to make you suggest over pneumonia. Or we can listen over the heart itself, listening for a murmur that might be associated with. That's not how you spell murmur. Listening for something like a murmur that might be associated with a valvular lesion, or maybe an S3 or an S4, which might be associated with hypertension or CHF. There's a lot of little things there that you can hear. So basically, it's a big screening tool. So what are screening tools? When we think about what do we do with the screening tool, remember there's always a screening. So you have something that you use to screen, and then after you screen, you go to a confirmatory test. So, and then what would be the confirmatory test for our cardiac abnormalities? It would be an echo. So basically, it is to see, do we need an echo? Not 100% to see if we need an echo, because you can't make a diagnosis with just physical exam findings, stethoscope, those type of things. But anyway, big picture here. I'm trying to think, what do we do with the stethoscope? I'm going to listen to this person's chest. Why am I listening to their chest? Hopefully, if they're talking to me, they have a heartbeat, right? So what am I going to be? Why do I keep doing this every day? Do I just do it for no good reason? No, we're kind of using it as a screening tool to look for other pathology. Do they have abdominal pain, decreased bowel sounds? Maybe need to get abdominal x-ray or CT to rule out a small bowel obstruction. Do they have a murmur along with shortness of breath? Maybe need to get an echo to rule out some valvular lesion. Do they have murmur suggestive of aortic stenosis? Maybe I've already made the diagnosis of aortic stenosis, but I want to see the severity to see if they need it surgically corrected, because they're complaining of some shortness of breath, but I'm not 100% sure if their shortness of breath is secondary to their valve lesion, or is it secondary to their COPD, those type things. So big thing is kind of a screening tool. Remember, we always do something as screening followed by confirmatory. The confirmatory test here is going to be an echo, and remember, goals are always good. It's always good to set goals. So we should have it on our desk in front of us as we're watching this video. We should have a number written down, which is going to be our step 2. Oh boy. STE. Yeah, you got it there. The right letters are there, just the wrong order. It's going to be our step 2 score, and we want to know what we want to make. So moving on from there. So looking at murmurs, when do we need to evaluate a murmur with an echo? So what echoes need a murmur? What murmurs need an echo? So basically, it's going to be any murmur that is symptomatic. So you have a valvular lesion that you feel is symptomatic. So they're having chest pain or shortness of breath, syncope, angina, secondary to their aortic stenosis or other valve lesion. This needs to be evaluated with an echo. If it's diastolic, it needs to be evaluated with an echo. If it's continuous, remember like our PDA murmurs, continuous machinery murmurs. If it's holosystolic or what's that other word? Pansystolic, yeah. So pansystolic or holosystolic. Remember, those are the same thing. So pansystolic and holosystolic are the same thing. Or if it's early or late, or if it's greater than or equal to 3 out of 6, mid-systolic. So I know that's a lot, but it's pretty easy if you kind of break it down. So first one is just going to be symptoms. And then, to me, it's basically, does it sound weird? So that means diastolic, continuous, holosystolic, pansystolic, early, late, and then, is it loud? So greater than or equal to 3 out of 6. So, um, loud, weird, which is diastolic, continuous, holosystolic, pansystolic, early, late, and then any symptoms. And remember, on a board exam, they're going to tell you. They're going to tell you it's diastolic. They're going to tell you it's continuous. Tell you it's holosystolic, pansystolic, early, late. So all these things are going to be given to you. The symptoms, might kind of hide that in there. It might be shortness of breath, might be chest pain, might be angina. Remember our classic symptoms for aortic stenosis, which is one they can kind of get you on this. It's the angina, syncope, and then the CHF. And the 5, the 3, the 2, or the 5, 3, 1, or the 3, 4, 5, whatever you saw as the kind of mortality rate if they don't get it fixed. So, and then who doesn't need their murmur evaluated with an echo? That's someone that's asymptomatic and it's a mid-systolic murmur that's 2 out of 6. So this is the question that I know I was asked a lot on step 2, which was, the young male that showed up for the insurance physical or the pre-participation physical for football or something like that, and he had a 2 out of 6 mid-systolic murmur, and they asked you, what do you want to do next? And it was just basically follow or nothing, those type of things. So that would be kind of where they were headed with this. And this one to me was the one I got asked the most commonly. Probably secondary was this one, which is just kind of when to evaluate. So now that we've decided what we want to evaluate, how do we want to evaluate it? So we know we want to echo. Do you want a transvaginal? No, you do not want a transvaginal echo to look at the heart. But you don't want a transabdominal echo either. But you might want a transthoracic or a transesophageal. So remember our transthoracic, that's going to be our TTE. Transthoracic TTE, and our transesophageal is our TEE. When we kind of look at that sensitive specific progression, sensitive and specific is not the best word here. This is what you should do first. This is more accurate than this, and the most accurate of all is your left heart cath. Remember, our left heart cath is most accurate of all for valve lesions. That's what we're talking about here. So for valve lesions, because you can establish a gradient, and that gradient is measured. I think I kind of spelled measured wrong there, but you get what I'm saying. So left heart cath, look for valve lesions, most accurate because you measure a gradient. It is not the most accurate establishing an ejection fraction. The most accurate test for an ejection fraction is a MUGA scan. And it's like a multi-nucleated gated something or another. Anyway, you can look up what exactly it stands for. But this MUGA is most accurate for your ejection fraction. Your left heart cath is most accurate for your valvular lesions because you get to measure a gradient. Remember, your gradient is calculated through some physics and some formulas, which can all be adjusted by how you hold the probe and those type of things. Also, with this MUGA scan, remember we're going to get this with someone that's on chemo. So we're going to have somebody on chemo, and they're on doxorubicin, whatever it is, doxorubicin, and they're coming in with some shortness of breath, and we're concerned that basically they're getting chemo-induced cardiomyopathy, and we want to get a MUGA scan to see exactly what their EF is and to see if it's dropped any, before chemo, post chemo, during chemo, see if we need to change that medication. So next we want to kind of look at the murmur location. We have our post, our aortic, our pulmonic, our tricuspid, and our mitral. You also have the, this left lower sternal border over here. And, here's just kind of the different murmurs that are classically at the spots. If you have a rip-roaring, really loud murmur, you can pretty much hear it anywhere you lay the stethoscope. So it kind of depends on, the intensity of the murmur as to what you hear where. The thing that I would note from this is that when they ask you a board exam question, they're going to give you the little man laying there. He's laying there on his back, and they're going to give you a chest with the post, where you kind of move the stethoscope around when they're trying to make it interactive. If you know the post, so let's say you don't hear a murmur here, you don't hear a murmur here, you don't hear a murmur here, you hear a murmur here, which is the mitral spot. Well, then you just kind of say, well, what murmurs can be heard at the mitral spot? Mitral regurg and then mitral stenosis are the main ones. So then did they tell you, was it a diastolic murmur or a systolic murmur? And if they didn't tell you that, maybe look at the carotid upstroke on the little dummy and see, do you hear the murmur getting louder when the carotids are bounding, which would be systolic, or do you hear the murmur best when the carotids are not bounding, which would be diastolic? So that's kind of the way I approached all that. And usually you could kind of eliminate down and end up getting the right answer there. So our other heart sounds, our clicks, our snaps, our ASD, VSD, and then our systolic and diastolic murmurs. Talking a little bit more about our systolic diastolic murmurs. For some folks, this is a little harder to kind of conceptualize than others. But remember, we kind of have our S1 or our S2. Sorry, this would be an S1. So remember, this is systole, and this is diastole. So do we hear the murmur during systole, or do we hear the murmur during diastole? Being, was it a systolic or diastolic murmur? Just talking about left heart murmurs because it's kind of easier to conceptualize. Remember, we have our aortic outflow tract with our aortic valve. Then we have our left ventricle, and then kind of coming into our left ventricle is, this will be our left atrium. Sorry, this is a terrible picture, but this will be our mitral valve. So when the left ventricle squeezes, so it is squeezing, there are two valves that can make noise. So it can either go out this valve, which is the aortic valve, and make a noise. And if it was to do that, it would be headed in the right direction. So the blood would be going where it was supposed to be going, but it would just be making an extra noise. So in that scenario, it would be aortic stenosis. So, and then it can go out the mitral valve. So, but that would be not where it's supposed to go. So it would be regurgitating through that valve. The valve's not stenotic, it's kind of floppy. So that'd be, your mitral regurg. You can also have your mitral valve prolapse in this scenario too. And then you can also have HOCM. But, those are kind of just different things. So eliminating this one because it's not technically a valvular lesion. Remember, it's just kind of a big bowed septum there. But remember, we have our heart sitting right here. We have our aortic valve right there. We have our mitral valve right here. As the heart squeezes, the blood only has, remember, because it's squeezing, so this is systole. The blood only has two ways to go. It can either regurgitate, which is the wrong way. It went the wrong way, so it regurgitated. Through the mitral valve, and this is systole, so it is systolic murmur, or it can go the right way, which is through the aorta, and you hear noise, so it is systolic and it's aortic stenosis. So, and then looking at that again, so we have our heart again, we have our mitral valve, we have our aortic valve, and those type things. So now we have the heart is relaxing, so it's relaxing, and once again, blood can only go two ways. So blood can either come in through here or in through here because it's not squeezing. This is diastole. It's not going to be going out of either one of those. So remember, our atria in this case is going to be contracting. So is it contracting, and we hear the blood going through something that's tight, but it's going the way it's supposed to be going. So that's going to be our mitral stenosis. Or is it regurgitating back, flowing the way it's not supposed to be going? Back through the aortic valve, which is going to be our aortic regurg. So these would all both be diastolic murmurs. So, and then if we kind of ratchet it on back, aortic regurg, mitral stenosis, and then looking over here, aortic stenosis, mitral regurg, and then you remember HOCM and mitral valve prolapses are also systolic murmurs. So just whatever you need to do to memorize that or learn that. To me, it's easier to think about than it is to necessarily memorize. But there's lots of good memory tools out there to help us memorize if we need to. So moving on from there, we want to look at kind of murmurs and their maneuvers and how we kind of classify them. The basic concept, and the one thing I would say, remember, if I had to tell you one thing to remember, is the concept of more blood, more murmur. So if you have more blood, you're going to get more murmur for everything except mitral valve prolapse and HOCM. So basically, if there's increased blood in the ventricle, that's going to lead to an increase in the murmur for everything except mitral valve prolapse and HOCM. So what does that mean? That means for mitral valve prolapse and HOCM, more blood is going to result in less murmur. So a decrease in the intensity of the murmur. So your murmur goes down in HOCM and mitral valve prolapse with more blood. For everything else, the murmur gets louder with more blood. So kind of makes sense. I hope you all understand that. So now we're talking about inhalation, exhalation, just kind of respiratory variation. Remember, with inhalation, we're going to increase venous return to the right heart. So that's going to increase our right-sided murmurs, which are going to be pulmonic stenosis, pulmonic regurg, tricuspid stenosis, tricuspid regurg. All of these fall into the more blood, more murmur kind of phase of this kind of basic concept. And with exhalation, remember the exhalation, you're kind of getting increased intrathoracic pressure, and that increased intrathoracic pressure is kind of doing an effective squeeze on the lungs, and it's kind of causing the capacitance vessels of the lungs to empty more readily, and that's going to all go back to the left heart, and then that's going to increase blood flow to the left heart, increasing our left-sided murmurs. So remember, so increased more blood, so that's basically increased preload, right? So we get more blood, preload got larger, so we're going to increase every single murmur except for mitral valve prolapse and HOCM. So aortic stenosis, aortic regurg, mitral stenosis, mitral regurg. All these murmurs are going to go up with a decrease in our mitral valve prolapse and our HOCM. And we'll talk about exactly why in just a little bit. So when we look at the physical exam maneuvers, you can look at them individually. So, you can have squatting, supine, leg raise, left leg raise out. Passive leg raise. Valsalva, standing, hand grip, amyl nitrate. You can look at all these maneuvers individually, which ends up being more maneuvers than there are kind of 4 categories here. Or you can look at it based off what does that maneuver do. So that maneuver will either increase preload, decrease preload, or it will increase afterload or decrease afterload. So if you think about it as to what the maneuver does, it makes it a little simpler. So instead of memorizing 8 things, you only have 4 things. So first off, increasing preload. So if we increase preload, that's going to be more blood back to either the right or the left side of the heart. For most of these, I'm kind of talking about the left side of the heart because that is our our functional ventricle there. Both of them function, but one of them is the one that we kind of refer to most, left ventricle, as it is the systemic ventricle. So we're talking about left sided stuff here. So from there, increase preload. So if we increase preload, that's going to be more blood returning to the left ventricle. So more blood equals more murmur for everything except mitral valve prolapse and HOCM. So those 2 murmurs will decrease with more blood. Every other murmur will increase. So aortic stenosis, aortic regurg, mitral stenosis, mitral regurg, all those murmurs will increase. So that's going to be anything that involves squatting, laying supine, bradycardia, passive leg raise, all that stuff will increase preload. Remember, bradycardia increases preload. Just secondary to that there's just more time in between contractions, so you have more time to feel and those type of things. Remember, for mitral valve prolapse, the murmur will move closer to S2, so it's going to improve because it occurs later. So we'll talk about this in a little bit, but for our mitral stenosis and our mitral valve prolapse, if those murmurs occur later, this is good. So this is not true for aortic stenosis. So later for aortic stenosis is bad. So that's just kind of a difference there that we need to kind of note. But for mitral stenosis and mitral valve prolapse, later is good. So meaning that the murmur decreases. And then remember, because this is a systolic murmur, we have S1, we have S2 here. So as it occurs later, so that means it occurs closer to S2. And we have S2 to S1, that's to be diastolic. But kind of going on from there. So more blood, more murmur for everything except mitral valve prolapse and HOCM. So increasing preload, it's going to be anything that does squatting, laying supine, bradycardia, passive leg raise, those type of things. So now we want to talk about things that decrease preload. So that's going to be like Valsalva, and that's just bearing down. So that increases vagal tone. That increased vagal tone will so increased vagal tone causes a dilation of our capacitance vessels in our legs, also throughout our body, abdomen, those type things, and it's going to decrease preload. So decreased return to the right heart, which then in turn results in decreased preload to the left heart. Tachycardia, so just less time to effectively feel. Anxiety, which results in tachycardia. Standing, just it's harder to get blood back up. So we have decreased preload with that. So less blood, less murmur. So because there's less blood around, you're going to get a decrease in all of our major murmurs. So our mitral stenosis, our mitral regurg, aortic stenosis, our aortic regurg. So less blood, you're going to less murmur for all those. More blood, more murmur. Less blood, less murmur. And that is, when I say less murmur there, I mean the murmur is not as loud. When I say more murmur, I mean the murmur is louder. So the murmur will increase with more blood. The murmur will decrease with less blood, based off this kind of basic concept. Except for, remember these 2 up here. So now talking about mitral valve prolapse and HOCM. So why do these murmurs increase with less blood? So why do the murmurs increase with less blood and decrease with more blood? And it has to do with kind of the functionality of the murmurs themselves. So for mitral valve prolapse, it's pretty easy to kind of depict. So remember, we'll say here's our aortic outflow tract, so we don't really have to worry about that. And then here's our two mitral valves. So our two mitral valves should be kind of touching each other like so. I know this is very, very, very rudimentary. But let's say in mitral valve prolapse, we have a little extra murmur, a little extra valve kind of hanging out on each other. So we have something like this. So we have all this kind of redundant valve sitting there. Well, whenever the heart starts to squeeze, it's going to be able to squeeze blood back through there because our valves aren't meeting up correctly. So, if we were looking at it kind of down on it, maybe our mitral valves are maybe they're supposed to be doing like this, where they're all kind of touching and everything's good and fun and awesome. But maybe instead they're kind of like laid on top of each other with like a crease in the middle. So it's easy to get blood back through. But as we increase blood within the left ventricle, so that's going to make the left ventricle dilate. And that dilation of the left ventricle, remember this is all kind of very small, but it approximates those valves. So approximation of those valves decreases the kind of the overlap area, decreases our redundancy, and there's less regurg back through that, so we don't hear that murmur as much. And remember, if the murmur improves, it's going to happen later. It's going to occur closer to S2. The murmur gets worse, it's going to occur closer to S1. So remember, more blood, more murmur for everything except mitral valve prolapse. So remember, we're going to get more blood, less murmur. So that means that more blood is going to cause approximation of the valves, and it will move closer toward S2. And then with less blood, you're going to get more of a murmur because, remember, with less blood, as our ventricle size decreases, we get increased overlap, and that murmur will move closer toward S1. We'll talk a little bit about that in a second. So then kind of going on from there for HOCM is basically the exact same thing. So remember, we have our ventricle here, and we have our aortic kind of outflow tract, and then our mitral valve and outflow tract. And, with HOCM, let's say we have this kind of big muscular mass just kind of sitting there. Remember, blood's got to all kind of squeezed through here. So as our ventricle size increases, so we have increased ventricle size with increased blood, so increased preload, because remember, preload increases all our murmurs except these two, so this murmur is going to decrease with increased preload. What's that going to cause? It's going to cause dilation of that ventricle, and maybe our little muscle mass that's over here kind of moves out of the way a little bit. So it gets kind of pushed to the side with that increased blood. And then with less blood, it collapses down upon itself, and maybe it covers up more of this valve, leading to kind of more of an area to try to squeeze blood through, which results in a little bit more of that murmur. So hope that makes sense there. If not, just kind of hit me up and we'll talk a little bit more about it. But now moving on to afterload. So remember, we can increase afterload maybe with hand grip or with worsening hypertension, or if we gave somebody like phenylephrine. Remember, there's a lot of little different maneuvers they can give you here to increase afterload. Remember, the thing you should kind of take away is the concept of what kind of increases afterload, the concept of what decreases afterload, the concept of what increases or decreases preload, and that will make this easier to remember and easier to get these questions right. So because we're not affecting blood volume here, what we are is affecting, basically our mean arterial pressure and stuff like that. The thing I like to think about is, we have our heart here again, and this is our aortic aorta. Remember, so the thing I like to think about with increased afterload is basically like if I were to put a cork in the aorta and basically said, all right, heart, squeeze against that. Let's see what happens. And then with decreased afterload, like if I were to just basically open this thing up and make it really easy to get blood out. So if I were to make it really easy to get blood out, basically decreasing afterload, all of my regurg murmurs would improve because there would be less backflow of blood. So the same goes for increased afterload. So if I increase afterload, all my regurg murmurs are going to worsen. So that's the kind of the basic concept of increasing and decreasing afterload. So increasing afterload, regurg murmurs worsen. Decreasing afterload, our regurg murmurs decrease. So it's going to be aortic regurg, mitral regurg. Those are going to decrease. Aortic regurg, mitral regurg. Those are going to increase with increased afterload. And remember, the case presentation for this worsening hypertension maybe can be somebody on 3 antihypertensives at home, and he ran out of the blood pressure medications. What would we expect to hear? He has a known aortic regurg. What would we expect to hear on physical exam? Worsening of his murmur. So this VSD. So this is a worsening of your left to right shunt of the VSD. So we put a cork So here's our little VSD. We put a cork over here, and we're not letting blood out of the aortic valve. So remember, blood's just going to take the path of least resistance, so it's going to be easier for our blood to shunt from our left ventricle to our right ventricle. Remember, if we decrease afterload, meaning we remove this cork, we open this thing wide open, we have our VSD right here, but the blood's still going to take the path of least resistance. If this is wide open, it's easy for blood to flow out of, blood's going to go through here. So it's going to effectively decrease our left to right shunt. But if we have, let's say we have Eisenmenger syndrome and we already have a right to left shunt, it's going to increase our right to left shunt. So with Eisenmenger syndrome, our shunt will increase, meaning our right to left shunt will increase with decreased afterload, but our left to right shunt will decrease with decreased afterload for VSDs. Now this is way over the top. I haven't really seen many, if any, questions on that, but that's just something I know is mentioned every now and then. So remember, decreasing afterload because we're going to making it easier for blood to be squeezed out of the heart. So it's going to kind of be a harder contraction. Our aortic stenosis, our HOCM, and our mitral valve prolapse, all those will increase. Remember, if our blood is flowing more easily through our aortic valve, and we're going to kind of get increased collapse. The increased collapse is going to kind of cause increased overlap of our mitral valve and worsening our mitral valve prolapse. And then, just more blood passing by our stenotic lesions of our HOCM and our aortic stenosis are going to cause increased noise there. So that's going to be what we hear. And remember, as our murmur worsens with mitral valve prolapse, it occurs earlier. As it improves, it occurs a little later. So, and then we know increase afterload. It's going to improve our HOCM, our aortic stenosis, mitral valve prolapse, and just that kind of goes with basically we have harder to squeeze the blood out. There's going to be a little bit more time in between our contractions, approximating our valves, and then for HOCM and aortic stenosis, it's going to decrease that gradient. So remember, increasing afterload will decrease a gradient, and that decreased gradient will lead to decreased sound of that murmur. So I hope all that makes sense. I hope that wasn't too confusing. You can kind of memorize this little chart here. I hope it helps. And if we need to, we can always talk about it in class. So just let me know.